responsive to PD5 inhibitors or people who have abused the drugs. Now we all know that the shockwave therapy has got multiple applications. 1977, Christian Chaucy has actually first time broken a kidney stone, which has become universal all over the world. It is also used in orthopedics, cardiology for failed bypass surgery, and the blocks would be blasted by the shockwave therapy. The intensity of the shockwave therapy varies at various specialties. Plastic surgery, neurology. We all know the supersonic plane, the gunshot, the lighting, everything works by shockwave. Now when we try to decrease the intensity and then use it for therapeutic purpose, what happens when a shockwave is given is high voltage is created, electrical spark discharge generated, the water vaporizes and creates an explosion, generating high intensity, high energy shock waves which are reflected by the semi-ellipsoid focused onto the treatment area. We are lucky in terms of erectile dysfunction because the organ is small, we can focus it thoroughly compared to other organs like lithotripsy, orthopedics and so on. Now if you see the focal point of shockwave therapy in kidney stones and the erectile dysfunction, it is 1/6 of the focal point. That's why the probe is smaller, and then it causes shearing stress and intracellular and extracellular responses, stimulates endothelial nitric oxide synthase, release of vascular endothelial factors, and proliferating cell nuclear antigen production, which leads to revascularization, which is the basis of shockwave therapy anywhere. Now they have been successfully used since 2005 to treat ischemic tissues in the heart and neovascularization and collateral formation. You see, this is a machine which is portable, can be used anywhere. We have used this since 2018. It was applied on the pineal shaft and crus in the 82 patients. We actually use 5 places. We start with the crus, where is the starting of the vessel, which is quite wide open. On the shaft, depending on the length of the shaft, we might do for 2 or 3 places on the pineal shaft. 3-minute application at each place. 300 shocks are given. It's quite painless. Patients easily tolerate that. And what it does is the calcium deposits microrealize on the vessel wall. When they are broken down, the elasticity also recovers. Now I covered the patient face and all, and this shockwave entirely it takes 15 minutes because 5 places into 2 minutes, and sometimes we give little gap. Entire shockwave therapy, actually 18,000 shocks are given weekly twice, and like that we have done for 12 sittings. So these are in 82 patients who are vasculogenic ED patients. We have selected only vasculogenic patients, median age of 62 years, and proved non-responders to PDE5, and erectile dysfunction duration was minimum 60 months. Efficacy measures were International Index of Erectile Function, ED domain score, and secondary measures are rigidity scale. Follow-up was done 1 month after shockwave therapy and 3 months of shockwave therapy. And then when we saw the results were out of 74 patients, what we have done, almost 80% have improved in terms of diameter of the vessel, the peak velocity, systolic velocity here, and you can see on the follow-up 1 visit, about 78% of patients have improved. One patient actually, he had 1 tablet of Viagra, which has actually given extraordinary good results, he said. So what we actually think is about 70 to 80% of patients improve who are clearly vasculogenic erectile dysfunction patients of all criteria. The study emphasizes the tolerability and feasibility of the vasculogenic ED patients, and no reported side effects. It was well tolerated, and it shows significant improvement remaining at least for 6 months. In fact, the literature says it can go on for 8 to 12 years. It can also be used for treating subgroup of severe ED patients who fail oral medication, and emphasize physiological effect of shockwave therapy on the erectile apparatus. Further studies are necessary to confirm this, and thank you very much.
Any questions from the audience?
Can it be given as primary?
No questions will.
Can it be given as a primary mode of therapy? Or you have to select your patient after the sequential therapy first?
Before the PDE5 drugs, you mean? Without giving any medicines first of all?
Yes.
So it's expensive. Generally each sitting around 5,000, 12 sitting is 60,000. Most patients already know, they have knowledge of the PDE5, they have used with the help of a friend or a pharmacist without our prescription. They have already used in a wrong way. And after that, when it doesn't work, or if it worked for some time, and then it stopped working, then they came to a qualified person like andrologist or urologist. So that's why very rarely a patient who comes for ED accepts a shockwave therapy as a primary treatment.
Kammela, one question.
What is the, your machine is electromagnetic or
Electrohydraulic, sir. Electrohydraulic.
so it damages more? What is the reason you have got an excellent result? How do you get such great success? I would like to have a Patnaik's opinion because he also does on electromagnetic machine.
Sir, actually the electrohydraulic shock, it's very slow, 0.09 joules per centimeter square. Most patients feel it as a vibrator. Many people are telling that it's a vibration only, it's a modified vibrator which we can purchase in 2,000 rupees and use it for face or elbow like that. But still, the technology is quite different, it is unique, and the focal length is most important here. I am not saying this is excellent result, sir. It's only 70%, 80% is not a very excellent result. There are 20% of patients who did
No,
not.
we don't get 70 to 80% in other modalities.
And
Even
and
if I do a penile prosthesis, I don't get 80% success in all the patients.
Sir, we have done for 462 patients. I have presented only 78 patients because these patients have completed 12 sittings. Many of them dropped out after 6 sittings because they felt it's okay. They didn't come back. There are a few patients who came back after 4 to 5 years and said, this much time we were happy, now we want another 6 sittings. That way, we don't have patients, many patients who go for 12 sittings, what is prescribed. If they do that, probably they'll get good results like what we have got.
Kammela, one last question.
Yes, sir.
See now, you have taken the patients, the series you have taken that were unresponsive to PD5 inhibitors.
Yes, sir.
Am I right? So,
Yes.
what are your selection criteria? When do you say that they are unresponsive?
The people who have used for the ceiling dose of the sildenafil citrate or tadalafil, indiscriminately, I have seen patients using 200 milligram of sildenafil citrate, tadalafil more than 100 milligram, 5 tablets at a time. Those are the patients who are totally unresponsive, either because of misuse or disuse. We can say they have not responded. Second, we are seeing peak systolic velocity, and on the Doppler we are seeing some interruptions, inelasticity. People who have not minimum PSV is not there. Those patients we have selected because they are vasculogenic. You have excluded neurogenic patients, diabetic patients who had Peroni because these patients I know they will not respond. The Peroni also we can use shockwave therapy, but the results are not very good. Only maximum what it happens is pain is reduced. Sometimes there is a crack in the plaque, but the erectile function is not very encouraging.
Thank you.
Thank you, Dr.
Thanks.
One listed poster has been missing from the provided booklet. It is by Dr. Manoj. This is the last activity of this session. It's a poster by Dr. Manoj Kumar.